Good morning, everyone. Hopefully everyone's joining. Welcome to the Treating Hepatitis C in General Practice Forum. So I'm your host, Bianca Lieber. I'm a Hepatitis C Project Officer at ASHM. To open today's forum, I'd like to acknowledge the traditional custodians of the land on which we live and work. Today I'm joining from Whadjuk Country, home to the Noongar people. We pay our respects to elders past, present and emerging and recognise any Aboriginal or Torres Strait Islander people with us today. This week is National Reconciliation Week, being a time for all Australians to learn about our shared histories, culture and achievements, and to explore how each of us can contribute to achieving reconciliation in Australia, remembering that always was, always will be Aboriginal land. I'd also like to thank our sponsors, Gilead and AbbVie, so we're very grateful for their support. An additional thank you to Queensland Health and the Kirby Institute UNSW for providing scholarship funding towards attendance at the 2021 Viral Hepatitis Conference. And a final thank you to the Kirby Institute UNSW for providing funding for the post-forum networking hubs. If you'd still like to attend one of these hubs, please email education@asham.org.au. So just a few housekeeping for today. So this forum is being recorded. So only the presenters and their presentations will be recorded and made available after the forum to rewatch, noting that attendees will not be recorded as by default, attendees' microphones are muted and cameras are off. Please use the live Q&A to raise any questions to the presenters. There's a dedicated Q&A at the end of each session. Please ask questions throughout and I'll raise where possible during the Q&A. You can also use the discussion forum to raise any commentary on the session. There will be an evaluation after the forum, so we encourage everyone to complete the evaluation for feedback on the day and continuous quality improvement for future forums. And if you require a certificate, please email Jane. And just a note on CPD, so this education is approved by the RACGP CPD program for 8 points. So if you can complete the post-course survey as part of that CPD. So just about ASHM. So if you're not already aware, ASHM is a not-for-profit member-based peak organisation for health professionals working in HIV, viral hepatitis and sexual health. We support our members and partners to generate knowledge and action in clinical management, research, education, policy and advocacy in Australia, New Zealand and internationally. ASHM run a suite of educational events to support the health workforce like today's, and we also administer the HIV and Hep B S100 community prescriber programs. So these are just some of our hepatitis C resources. So we have the decision-making tool and the viral hepatitis mapping report. Also, please consider becoming an ASHM member. ASHM membership plays a critical role in supporting our work in policy and advocacy and workforce development. As a registered charity, we also rely on membership fees to support our unfunded work. So just a brief overview of the purpose of today. So the purpose of the forum is to bring together general practitioners from around Australia to discuss their experiences, strategies for success and innovative models of care for the treatment of people living with hepatitis C in a range of primary care and priority settings. GPs are often the first point of contact and provision of continuing care for people living with hepatitis C. They play an important role in not only screening people at risk for hepatitis C, but also promoting lifestyle modifications, management of other comorbidities, and since 1st of March 2016, providing treatment, therefore reducing the mortality of hepatitis C and advanced liver disease. Treating in primary care is very suitable for most people living with hepatitis C, especially the estimated 90% of patients with no evidence of cirrhosis. So this is an overview of the program. So each of you should have been emailed this program before the day. Unfortunately, I couldn't fit in the breaks because it's quite a condensed program into this slide. But I'd like to give a big thank you to the General Practitioner Advisory Panel for their support in developing the program. So we have Dr. Belinda Greenwood-Smith, Joss O'Lone, Dr. Nada Andrick, and Dr. Sam Elliott as well. These are the learning outcomes for today. I'll let everyone read them very quickly. Okay, so I'll just do a quick poll to figure out who's joining us today. So our first poll is, what is the state or territory of your main practice? So Kara will just launch a poll now and it should be in your right panel if you can enter your answers there. Cara, have you launched that poll?
Yep, the poll has been launched. Bianca, participants should be able to see it on the right of their screen. It's got 7 people who have voted so far.
Interesting. I can't see the results of the poll. So if you could let me know who we have, that would be great.
No worries, you've got 14% in New South Wales, 43% in Victoria, another 14 in South Australia and 29 in Queensland. And somebody's just joined us from TAS.
Thank you, Cara. So the next poll is, in which setting do you work? Cool. And Cara, if you could just let me know, because for some reason it's not showing on my screen, it just says start the poll.
No worries at all. I think there's a bit of a lag there. Sorry, Bianca. So we've got 8 people who have answered, 63 are in general practice, 13% are in a sexual health service, and then 25% have indicated other.
Well, that's positive. We've definitely targeted the right people for the forum, so that's great. And the third poll is, have you ever tested anyone for hepatitis C prior to today? I suppose it's a little non-specific because this could be antibody or RNA, but we'll take whatever. Cara, can you let me know the results?
Sure. So we have had 6 people respond. Sorry, 7 people respond now. 86% of people have said yes and 14% have said no.
Good. And then the final poll is, have you ever prescribed hepatitis C DA therapy prior to today? And Cara, sorry, if you can just let me know the answers again, thank you.
No worries at all. So we've got 7 people who've responded, 71% have said yes and 29% have said no.
Good, that's good. Okay, well, that's all from me. So I'm now going to introduce our first session presenter, who's Dr. Nada Andrick, Chair of the General Practitioner Advisory Panel, and also a General Practitioner for the New South Wales Refugee Health Service and General Practitioner in Private Practice, who will provide the opening address to the forum. Thank you, Nada.
Thanks, Bianca, and welcome to everyone today, and thanks for joining us. I'm currently on Yagara and Turrbal land here in Brisbane, and it's a really lovely day, so I would like to also acknowledge the traditional owners of our land here. So I guess as a welcome, I'd really like to welcome everyone to today. It's a really interesting kind of day. I don't think I've ever attended any sessions quite like the GP Forum for Hepatitis C. It's always a good day because we get to hear from general practitioners across Australia who work in very different environments, in very different settings, about the ways they manage hepatitis C in their practice and the ways people approach hepatitis C in their community setting. And the sharing of those ideas is really important because really most people end up going home with some new ideas on how they could manage hepatitis C in their practice, but also how they can manage different kinds of issues in their general practices and apply them as well. So I guess today is a bit of a call for action. I've asked Bianca what I'm meant to speak about, and the first bit is a call to action to pretty much say that hepatitis C is really easy to treat, and it's actually something that I really enjoy treating because there aren't too many things that you can treat quite easily and get a bit of a buzz out of. There aren't too many chronic diseases that you can cure, and in general practice we end up managing people for a long period of time with things that are very difficult, and it is quite nice that, you know, by far and away, treating hepatitis C is pretty much a 6-month kind of task. So I really enjoy it. I like the feeling that I get in telling people that they don't have a virus anymore. And it's something lovely that you can share with your patient that I don't think many other people get to do with many other issues. So I got into hepatitis C mostly through the work I was doing in a drug and alcohol service, and one of my patients wanted to join the army and get rid of their hep C. So it was a great motivating factor, and I think it really changed the way I saw things, and I realised that actually it was really quite easy. So it led to a lot of changes in our practice, and it gave a lot of our clients in our homeless health service confidence to, I guess, approach other medical tasks once they could see that they could get some success from approaching this task. I'm a bit nervous because I don't have any slides, so I'm going to just show you one thing. I've moved from Western Australia to New South Wales, and I just wanted to figure out where our local NSP was. So I had a look, and we'd have a vending machine at the community centre where I work for refugee health services, and it's not very inviting, but we do have a vending machine. So the vending machine is actually that blue sort of grey machine there, and you can press all of those buttons, and they're all $2 each. And you can get your fit pack, and right next door is that sort of yellow bin where you can dispose of your contents. And I wanted to know what $2 would get me, so I opened up the little black box of the fit pack, and it was 5 needles and 5 alcohol swabs. And a spoon and some water and a little contents list. And I realised that actually this is sort of a bit of a missed opportunity for education and even inviting people for further, I guess, engagement, not just sort of at the dispensing point, but sort of, I guess, engagement from a point of view of actually, do you think about sort of, coming in and getting a test? So I think, when I worked at the needle and syringe program in WA, there were definitely health messages inside our fit packs, and I realised that this isn't something that's kind of uniform across Australia. So that's something that I think we could probably improve and work on. And I think this is something I guess we could all share during our sort of one of our sessions today, which is where we'll be just talking with each other about practical strategies to improve testing and treatment. So I encourage everybody really to figure out where their local NSP is. It could be the local hospital, it could be their local community centre vending machine, but it would be good, and even the pharmacies, but certainly knowing where to direct your patients is an important part, I think, of becoming quite a hepatitis C treating friendly practice. So today's sessions are really great. We'll have, we've kind of carved it up into a few sessions. So the first session will be with Dr. Bouchal and Professor Dorr, giving us an update on hepatitis C. And we're going to go into some GP-led talks in the health of marginalised populations, and we also have a lovely invited speaker to talk about their lived experience, which is fabulous. Our third session will be a workshop session where we can all talk with each other and about some of the strategies to improve testing and treatment in our practices, and then we'll go into some more gutsy models of care talks, as well as finishing up with some difficult case sort of management studies with some co-infection cases. So I think we've got something for everyone today. And I think that's about all from me. I'm not sure if Bianca, you want me to say anything further. This is the call to action part, but I'm just really happy everyone's joining us on a Saturday. I really appreciate everyone's time. I know that we're all a bit zoomed out, and I know that I'm exquisitely COVIDed out, even though I'm not in Melbourne. And thank you to all the Melbourne people for joining today. I really, I think it's such a difficult time for all of you. So thanks for coming. But I think COVID's definitely put a real strain on the way we see hepatitis C as well. And it's time, I think, for all of us to get back on track in primary care. And push through the vaccines and then also sort of re-engage with our patients on a face-to-face basis and try and get some of these chronic diseases under control again. So that's all going to be a bit of a challenge, but I'm sure we can all do it.
Thank you, Nada, for giving the opening address. So our next session presenter is Dr. Roshan Bushell. He's ASHM Hep C Board Subcommittee member and Senior General Practitioner and Lead Clinician at the Aboriginal and Torres Strait Islander Health Community Service. He's also a Senior Lecturer at the University of Queensland. So Roshan will be providing an overview of the Australian recommendations for the management of hepatitis C care and important updates to prescribing as per the consensus statement. Thank you.
Good morning. Thank you, Bianca. Good morning, everybody. So as Bianca said, I'm one of the general practitioner in Aboriginal Medical Centre in south side of Brisbane. Hello to everybody from all over Australia. I think I've met quite a few people because I did a similar presentation a couple of years ago in Adelaide and the last conference in Sydney, in GP Forum. Today, I'll be basically talking about a bit of overview on our consensus statement in managing hepatitis C in Australia, which is probably the most important single document as a reference tool for us as a primary care provider. Now, I got involved in hepatitis C when I joined AT6, the Aboriginal Medical Centre here in Brisbane. As you know, we deal with higher burden of disease in this demographic. And my journey started from attending one of those education sessions by ASHM back in 2016, I think. Yeah, and then we came to the practice and went through the database search to see how many existing hepatitis C patients we've got in that system. And then that's where we kind of did a bit of data search to find about 140 patients, 142 odd patients in our database already existing hepatitis C patients. So, and then we started making a phone call to get all those patients into the clinic. And out of those 140, I think we got about 106 people back in the clinic, had the blood test done. And 11 to 12 of those people had RNA PCR negative, so they didn't need a treatment. So we had just over 100 people, those need to be treated. So they are the already existing people. So just a little snapshot of how far I have come across treating Hep C in the current workplace in managing Hep C patients here. So this is just a bit of overview. Since then, we initiated treatment on about 89 patients. 76 of them have successfully achieved SPR, and the 9 of them are still on the treatment. I should admit that we've been a bit slack since last year. 3 of the patients have failed SPR. One of them actually went into prison and lost the follow-up. Another person, I couldn't trace him. We started him, prescribed him medication, but then disappeared somewhere. I couldn't locate him again. Third one was actually not the failed, it was actually the reinfection, because patient did take the tablet and at the end of the 12 weeks, PCR came positive. So I went ahead and did another genotype test that came out as a new genotype. That's why that was actually reinfection. So among all these bars, I think the most exciting thing for us has been that self-referral. The reason I put that number there is because this is what we're trying to achieve in Indigenous practices, that people to come forward and ask for treatment. So these 14 people were the people that we did not call them to come to the clinic. They actually came to us asking to get treated. They said, hey, I've got a Hep C. Somebody told me a few years back, I'm here to get treated. So those are the numbers that we're focusing here. So just looking at general trend, just looking at the trend, as with national average, I suppose, I'm sure the Greg will tell us a bit more about how we're going with the prescription. So we started brainstorming around 2017, and then 2018 and 19, we did pretty well and treating people and prescribing. Then, yeah, end of 19 and since last year, 2020, we became slowish. So I've got just under 20 patients in the clinic now that need to be treated. So this is basically what we're going to talk about today. I'm just going to give you a bit of brief overview about the recommendation in this document. This is a very well-written reference tool that we need to manage Hep C in primary care. This document is very simplified and divided into different sections, and it talks about the different sections, including the model of care in Australia, how we screen, how we diagnose people, and what are the assessment that we need to do just before we start people on treatment, and what we need to do during the treatment, and what happens after the treatment, how we follow these people around, and does talk about chronic Hep C in a very special population like indigenous population, people living in mental health, and Hep C in IV drug users. So it's a very well-written document and very easy to follow through. We're not going to go into detail about all this section. I don't think we'll have time to go through all this, but I just want to do a bit of highlight about how it goes. It tells us about who to screen. So it just gives us a list of all the high-risk population which should be who should be in our screening radar. And then it goes to how to screen and diagnose. So how should we do this? So once we start thinking about Hep C and we start screening people, then we start screening simply by doing the antibody test first. And if the antibody test comes negative, we don't need to do anything from there. If it comes positive, of course, we go ahead, bring the patient back, do the RNA PCR. That's the one single most important test that determines whether patients need treatment or not. If the PCR comes negative, there's no active Hep C infection, so it doesn't need treatment. If it comes positive, then we need to bring these people and start treatment. So yeah, simple guidelines to follow through about how we should screen and diagnose these people. Now, pre-treatment assessment, trying to just summarize here, basically there are three things we're going to do. Get a bit of detailed history and the physical examination and some investigation. The history is to pretty much to establish the duration of Hep C, how they got it, whether they had any previous treatment, or are there any other co-factors or co-infections. And then we go through other medical comorbidities and look at the social issues, which is one of the important determinants in the setup that I work, because there are lots of barriers to medication adherence and compliance. And then we go ahead and do a quick physical examination of these people. The physical examination pretty much is to just establish the complication, whether there has been any feature of liver damage or liver cirrhosis. Investigation-wise, apart from routine investigation, I'll probably just focus a little bit more on the Hep C, hepatitis C RNA PCR. As I said before, that's the single most important test that determines whether the patient needs treatment or not. Now, genotype, we do one test that was recommended before, which is not a mandatory test these days because we do have a fantastic pan-genotypic agents these days. We'll talk a little bit more about those in the subsequent slide. And then we look at the co-infections, any hepatitis B or HIV or hepatitis A virus infection. And if we're treating under women of a fertile age, then of course we do a pregnancy test because none of these antiviral drugs are safe during the pregnancy. And the fibrosis assessment, another thing, there are two ways we can actually do them. Either do the biochemical assessment, which is the APRI score, where we simply need to know what the patient's platelet count is and what the AST is. And if the APRI score is less than 1, we can be fairly confident that the patient is non-cirrhotic and we can start the treatment there. However, if the patient does have any other cofactors that are affecting liver, and if they're high risk of developing cirrhosis, of course, we should go ahead and do the FibroScan. So what I do in my practice is I do the APRI score. If person is less than 1, I start them treatment. I don't hold the treatment just to get the FibroScan ultrasound. If the APRI is less than 1, I start them the treatment. And as we go through the treatment, and somewhere in the treatment cycle, if I see the patient is a high risk of having other cofactors that could actually come and hit the liver, then I do ultrasound or the FibroScan. But if somebody's got already established cirrhosis, they should have a 6-monthly ultrasound to screen for hepatocellular carcinoma. And of course, just to make sure that there is no cardiac comorbidities there, because if we are planning at all to start people on ribavirin, it's a very unusual agent that we use in general practice anyway. And the treatment, see, once we do all the biochemical or radiological marks and look at the patient assessment, if the patient is likely cirrhotic or if the patient has received any sort of treatment in the past, we simply just discuss this with the specialist and refer it to the specialist. So we don't deal with them in the primary care. And if the patient is non-cirrhotic and had never experienced any treatment, and this is where we go and prescribe them with the tablets. Now, just a quick summary, there are two pan-genotypic agents that we prescribe. So the first agent is a combination of sofosbuvir and veltasvir, which is in the brand name of Epclusa. And another is a mavorate, which is a combination of gilkakabir and preventivir. They do have a similar efficacy. The only difference is the pill burden and the duration of treatment. If we're prescribing Epclusa, it's 1 tablet a day for 12 weeks. And if it's a mavorate, it's 3 pills at once every day for 8 weeks. So the only difference is the duration of the treatment and the pill burden, as you can see there. Now, so during the prescription, and there's a fantastic tool developed by Liverpool, which is a drug interaction tool. You can just put the antiviral that we're going to prescribe and put other medication that patient is taking. That gives us pretty much like a traffic light system. And then monitoring, now, like with the treatment agents and treatment, the drugs that have come through, monitoring during the treatment has also become very simplified these days. Initially, when the direct-acting antiviral came in, I think it's the first consensus statement that on treatment monitoring was scheduled at, okay, we start something at week 0 and week 4 and into the treatment 12 weeks. But basically now things have been simplified. We really don't need to do any of these, though, unless there is some other risk factors. So it has to be individualized. But in general, we don't have to do any monitoring during the treatment. The only most single point is 12 weeks post-treatment, where we bring patients back and check their Hep C, RNA-PCR to confirm that they have achieved SVR, and we do liver function test. So the purpose of doing the liver function test here is first to confirm that it has normalized. If not, if the liver function hasn't been normalized, this is where we need to bring those people and find out what's causing the liver to be upset. So other causes of abnormal liver function test. So once we treat people and the post-treatment follow-up, so that once we treat the people, if the patients have successfully achieved the SVR, if they are non-cirrhotic, if the liver function test goes back to normal, we don't need to do anything for those people. They have achieved the SVR, but the liver function tests are still abnormal. This is where we bring the patients back and start looking for other causes of liver disease, including other autoimmune causes. And they may actually need to refer to the specialist. But if the patient has achieved SVR and has got ongoing risk factors, that's where we put them in an annual RNA-PCR test. If somebody has achieved the SVR, if the person is known to be cirrhotic, then they require long-term monitoring, especially for hepatocellular carcinoma, esophageal varices, and for osteoporosis. So this is basically the simplified guidelines that the consensus statement talks about. Now, what had changed if this is probably something that we'll focus a bit more today. What had changed if historically, if we look at in the last couple of decades, Hep C treatment had changed significantly, starting from injectable agents with intolerable side effects to the oral antiviral agents these days with virtually no side effects and better cure rates. Hence, after 2016, even after direct-acting antivirals were previously listed, it has gone through a series of changes. Now, when they were listed, there were very specific agents for specific genotypes that we're prescribing. But now we don't have to worry about a specific genotype and a specific agents. All we can just do in the general practice is focus on those pan-genotypic agents and start treating people here. So basically, when we talk about changes, every single change that the Hep C treatment has gone through, it basically has simplified the process both for the healthcare provider and for the patient. So I'm going to highlight a few changes in the last couple of years. And now there is a third agent, pretty much the three things combined into one is another pan-genotypic agent that's been listed for the people who failed to achieve SVR after the first-line antivirals and direct antivirals or NS5A inhibitors. And then, as discussed briefly before, we don't really need to worry too much about a genotype to start people on antiviral these days. However, if we're not using the pan-genotypic agent, still we need to have genotype documented in the patient's file. And another important role still the genotype plays is because I have a experience with one of my patients when the patient got when patient could not achieve SVR after 12 weeks of treatment. That's why I did the genotype to find out that it was actually a reinfection rather than failure to treatment. So when the patient's SVR, patient did not achieve the SVR and they come up with a different genotype, so that tells us that patient was reinfected. And again, when the agents were introduced, there were nothing for people under 18 years of old, but now there are agents that can be prescribed for people under 18, but that had to be dealt by the pediatrician who are experienced in treating Hep C. Another important changes have been the prescribing by the nurse practitioner. So they can now nurse practitioners can prescribe antivirals under PVS general schedule. And recently, the TGA has approved the point of care test for Hep C RNA. That was in May last year. So basically, this is a bit of highlight about how things have been simplified actually. And just, yeah, so this was actually pretty much the final slide, but I just wanted to quickly mention about the barriers that would come across in my personal experience treating indigenous population here. When we talk about the barriers, we often talk about the barriers related to the patients, but I want to focus a little bit on the healthcare providers related barriers, because when I say healthcare provider, it's not only the general practitioner. I'm addressing registered nurses working in the clinics, Aboriginal health worker, community liaison officers, all those things. So how they perceive treating Hep C, this is something that we experience here. So there is still a fair bit of concept that treatment isn't accessible to people who are still injecting drugs. If you're asymptomatic, that means Hep C is fine. Your Hep C remains dormant, you're a carrier. So, and then sometimes, yeah, I don't think the work is that difficult because of the very straightforward guidelines these days. And what you realize is every single of this information works as a barrier to access the treatment. And the patients-related barriers are nothing new. We all pretty much know about the things people often think that, oh, because I'm asymptomatic, I don't need the treatment. I'm really worried about the side effect that people talk about, especially the interferon-related side effects from the good old days. And some people, yeah, they may have some other competing priorities. I'm concerned about being discriminated. And then, yeah, still there are people who come and tell, no, we didn't know that there was new tablets available for treatment. So yeah, just to summarize, a bit of what are the barriers and what are the enablers. So it's a bit of a busy slide, I'm sorry for that, but I've just kind of listed what we've come across. So it's still, the barrier seems to be overweighing a little bit. Okay, thank you. That's my final slide.
Thank you, Rashan, for your presentation. If you just stop sharing your screen. Yep, great. Thank you so much. If you've got any questions for Rashan, we'll have a dedicated Q&A at the end of the session. So if you just add your questions to the chat or the Q&A, sorry. So our final session presenter for this session is Professor Greg Dorr. He's the program head of viral hepatitis clinical research program at the Kirby Institute, infectious disease physician at St. Vincent's Hospital, Sydney, and NHMRC practitioner fellow. So Greg will be providing an overview of the epidemiology of hepatitis C in Australia, including data trends of GP prescribing. Thank you, Greg.
Thanks very much, Bianca. It's great to have the opportunity to present in a really important forum that we have every year. So I'm going to quickly go through some patterns of DA prescribing, talk about some treatment outcomes from a large observational cohort we have here at the Kirby called REAP-C, the impact of COVID-19 on Hep C sort of testing and treatment, some future directions in terms of Hep C elimination. So many of you may have seen this slide before, this incredible sort of change from the interferon era to the DA era. We've now treated pretty close to 100,000 people with chronic hepatitis C in Australia, really quite remarkable. And that estimate is edging up to around about half the people we believe have active infection in Australia. But you can see that the drop off every year. So we clearly need to stabilize that pattern and hopefully get a bit of a bump in the sort of post-COVID setting. Onto the patterns of prescribing, comparing specialists to non-specialists. The general practitioner class here doesn't include some other non-specialist sort of groups that you wouldn't traditionally call GPs. but it clearly shows the increasing proportion of people in Australia treated by a non-specialist. Absolutely crucial foundation for providing broader access. We've also looked at the number of new prescribers each quarter. So you can see in the dark green, around about 10% of scripts each quarter are written by someone who's writing their first prescription. And I think that's a really important ongoing aspect of the rollout of DA therapy. We'd love to get more people involved. It's just such an empowering area of clinical medicine to be involved in, the ability to cure people so readily. So it's great to see more people coming on board each quarter. So here's the REACH-C cohort. We have over 10,000 people in the database. So this is people that have initiated DA therapy since March 2016. And we've compared the demographics and baseline sort of regimen information to the PBS data that we have. So pretty comparable. And you can see general practitioners, about 23% in the REACH-C cohort, 29% in the PBS sort of data, and other physicians as well. And I'll just take you through some important sort of outcomes. So we look at the treatment outcomes in two ways. So the very strict way that you look at the rate of cure is what we call intention to treat. So commence someone on therapy. If you don't get a post-treatment test for cure, then you assume that they have failed treatment. Now, clearly that's not the case. In fact, I believe the large majority of people who don't come back for their post-treatment assessment still have cleared the virus. But it's important, I think, to present both the intention to treat and what we call the per protocol treatment outcome. So that's based on the people who have had a test to see whether they've been cured or not. So if you look at the per protocol, it's around 95% among those over 10,000 people. And because we've had this sort of loss to follow-up proportion, about 16%, then the intention to treat comes down. If we look at the various prescriber types, you can see general practitioners there, 96% in terms of the per protocol treatment outcome, 77% for the intention to treat. So a little bit higher sort of loss to follow-up compared to the specialist sort of clinics. If you look at the setting as well, pretty comparable as you'd imagine in general practice, so 96% and 78% for those two categories. So I think the main message from this is that Hep C can be incredibly effectively treated across the range of prescriber types and across the range of service settings. I think it's interesting to look at the virological failure retreatment. So a small proportion of people do fail therapy. But I think the message from this slide is that retreatment of virological failure can be effectively achieved in different service settings. So I think, conservatively, many people believe that, well, if you have virological failure, you should be referred to a specialist sort of centre for further assessment and treatment. But it's pretty straightforward, as Roshan outlined. We have a new therapy that's available for treatment of virological failure, very effective as a 1 tablet daily for 12 weeks regimen of sofosbuvir plus filpadosvir plus foxglaprovir. So that can be delivered in primary care in people that have had virological failure. You can see the treatment outcomes across the different groups. So whether retreated virological failure overall, 81% cure, which is a little bit lower than the initial treatment as you would anticipate, lower in people with cirrhosis. But if you look at the retreated in tertiary care, retreated in primary care figures, incredibly similar outcomes in those two settings. So whether you're retreated by a specialist or retreated by a GP, no difference at all in terms of those outcomes. Just wanted to briefly talk about reinfection. I think reinfection is even easier to treat than virological failure because people have a new virus. It's not a virus that might have resistant mutations. Therefore, they should be fine with a sort of first-line treatment regimen, either one of the two pan-genotypic regimens that are used. So within the database, we have 88 people who've been retreated for diagnosed reinfection. There may have been other reinfection cases that haven't been diagnosed or retreated, but these are the 88 cases we have in the database. And you can see the split there by genotype, as you'd expect, according to the circulating genotypes and the regimen that's been used for retreatment of reinfection. So these are two first-line regimens. So you don't need this 3-drug regimen that we use for treatment of virological failure. You can go with the first-line treatment regimen. You can see some people have been treated, well, in fact, most people have been treated in primary care. So, and the characteristics of that group is quite interesting. Not surprisingly, the large majority of people who report recent injecting drug use, fairly decent proportion of people from the prison setting, and the lack of needle syringe programs in the prison setting clearly increases the risk. A small number of people with HIV co-infection. But then if we look at the outcomes in terms of the treatment outcomes for reinfection, so the initial treatment, this was the outcome from their first treatment, the 95% cure rate per protocol. As you can see, the treatment outcome per protocol exactly the same as the treatment outcome as the first sort of treatment. And that's what you'd anticipate. These people have a new virus using a similar potent regimen for a first-line sort of treatment, and we're getting incredibly high rates of cure. But we're getting a high proportion of people not coming back for their post-treatment assessment. That's not surprising, given the group of people who are at higher risk of reinfection tend to be a group of people that's a little bit harder to follow in clinical practice. So that's why you get this sort of higher treatment loss to follow-up. You can see retreated in tertiary care, retreated in primary care. In fact, per protocol, everyone's been cured in terms of treatment of reinfection, so which is great news. And also retreated in prison, good outcomes per protocol. Just briefly, everyone's concerned about the impact of COVID-19 on treatment numbers. But if you look at the actual data, it was pretty stable in terms of monthly numbers. We were treating about 1,000 through 2019. In fact, the dip was before COVID. So we came down from late 2019 through to March 2020 in terms of monthly treatment numbers. And then they somewhat sort of stabilized through 2020. So I don't think COVID's had a major sort of impact on treatment numbers, to be honest. Hopefully we can keep them at least at that level through this year and possibly even increase. Just very briefly, the impact the treatment's having on some key markers. This is the needle and syringe program survey that we run through the Kirby here. This is a report through that survey of the proportion of people that have ever been treated with hepatitis C. So 10% back in 2015, up to 64% reported in the survey in 2019. The 2020 data is just about to be released. And incredibly encouraging reduction in the proportion of people with active infection. So these people attending NSP sites have a dry blood spot sample taken, and we do a test for hep C RNA on those samples. Half of people who injected drugs back in 2015 had active infection. We've got that down to 18%, and hopefully the 2020 figure will be even lower. So really encouraging sort of impact that we're getting at the population level. So this means reduced reservoir of infection. It also means reduced risk of reinfection because you're shrinking the pool of active infection. So that's good news sort of going forward in terms of overall clinical management. Obviously, reduction in numbers of new cases from this sort of pool of active infection. Okay, so what do we need to do going forward? A few key things. Continue use of diverse models for care. Australia's done incredibly well in that regard, but we can even do better. Enhanced Hep C screening. We've still got a large number of people that haven't been diagnosed as in terms of RNA sort of testing, and the linkage to care. And Rashan mentioned the point of care being the TGA sort of approved now. We still need to get a Medicare item and laboratory oversight of that. We might be able to address that in the Q&A sort of session. Integration of Hep C screening within drug treatment, homelessness and mental health settings, simplification of treatment assessment and delivery, as we've mentioned, increased treatment in prison and community PWID sort of populations. So we've got a few projects sort of looking at that specifically, and ongoing monitoring and evaluation. So just finally, thanks to all the people here at the Kirby and UNSW and collaborators nationally and internationally, and our funders. Thanks very much.
Thank you, Greg, and also thank you to everyone from session 1 for presenting. We don't have any questions currently in the Q&A, but we have 5 more minutes left for Q&A in this session. So I guess I'll ask a quick question to the panelists. So I suppose, how can we better embed hepatitis C care into general practice as business as usual, and just streamlining it into the current process and protocols that we have, rather than being, that's probably my question. So I'll give that to Greg. His microphone's off mute.
Thanks, Bianca. Look, I think it's going okay. Some people get pretty depressed about this, but I think the numbers are are pretty good. We're still treating large numbers of people. I'm really encouraged by the sort of the REACH-C portal that a lot of primary care prescribers are starting to use, and some nurse practitioners now, and that's functioning really well. So that's a system whereby people who are inexperienced send us through sort of the standardized sort of details about a patient. We give them a sort of approval within 24 hours sort of turnaround. We often sort of interact in terms of key questions on the case, and it's a really nice sort of method of mentorship, I think, for our less experienced prescribers starting out. So I think we should promote that sort of system more widely. And I think, as Nada sort of outlined earlier on, and as I sort of briefly mentioned, we just need to promote the sort of empowering capacity of Hep C treatment. And in a busy general practice with a lot of complex chronic disease management, here's an opportunity to sort of cure a chronic disease with a pretty reliable sort of well-tolerated intervention. And it's amazing for patients, obviously, but it's also a really empowering sort of involvement by practitioners. So I think we need to get that sort of message out, and people sort of look through, test the people that haven't been tested that may be at risk, etc.
Thanks, Greg. We actually have another question for you from Nada. Nada wants to know whether DBS tests are available across Australia and across settings, and whether there are any barriers to that. Yeah,
like it's a good question, and we've got to address the point of care sort of as well as the DBS. So the point of care is through this sort of new technology with a company called Cepheid that have got a finger prick sort of test. Gives you a result within an hour. The machines are not inexpensive. Even though the TGA has approved that, it needs to go through a whole range of things to have laboratory oversight, to be able to use those machines in different sort of settings, and the connectivity of those machine results to the laboratory reports and notification systems needs to be sorted out. So there's a whole range of things that are moving ahead with that. On the DBS side, the problem is that the companies need to file to add DBS as a sample type to their approved assays. So we've got approved assays for Hep C RNA detection, but the companies need to be motivated to put in a submission to have DBS added in. It currently is not an approved method for Hep C RNA detection. All the studies show it's highly sensitive and specific. It's great in research context. But the companies need a bit of a prod, and we're trying to sort of do that to enable DBS to be available more broadly. So it's good. It would be great to have both options. Now, DBS still needs a turnaround, needs to go to the lab. It might take a week, for a result to come back, etc. But it's a finger, it's a finger prick sample, and that's very suitable in certain contexts.
Thanks, Greg. And I'm assuming this question is also for you, very popular. We've got 1 minute 30 to answer this question quickly. So from JP, can you please reiterate the pockets of Hep C infection in Australia, injecting drug users, men who have sex with men, prisoners, where else is it prevalent?
Look, it's a good question. We've got a minute. So look, I think there's clearly two broad populations. There's a population of people that are highly marginalised. I said the RNA rates have come right down for people actively injecting, but there's still 18% of that group. So there's still probably 20,000 people out there. And they need to be reached through a range of settings where people inject drugs interface. There's people in mental health, I think, populations broadly, also marginalised, homelessness. So they're the key sort of marginalised populations. But then I imagine there's still a large number of people out there in the broader, more general sort of population. And that's a tougher sort of one because they're harder to find in a sense. So I think we do need some targeted, more broad education about Hep C, the curative capacity of treatment. We need more of what we're doing now, sort of GP sort of education, getting more people involved, a bit more sort of emphasis on case finding in practices that may not have been involved. And there's still a lot of methadone, buprenorphine prescribers that have still got large numbers of people that haven't been treated. So we're doing pretty well on that front, but I think we need to try and motivate the additional people to come on board.
perfectly answered in a very short amount of time. Thank you very much. So that's all we have for Q&A for this session. Thank you again to Nada, Roshan and Greg for presenting. So we're going to have a quick 10-minute break and then we'll be moving into our next session, Health of Marginalised Populations at 10 a.m. Australian Eastern Standard Time. Thank you.
Have a great day, everyone.